atherosclerotic cardiovascular disease, flashback and vision ahead. The last couple of years has witnessed a sea change in lipid management, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. The big messages are that we are very clear LDL cholesterol is causally related to atherosclerotic cardiovascular disease. The second big achievement is LDL cholesterol at the present state of time can be cut to any size by current pharmacotherapy. And the next message is, if you reduce LDL to around about 65, this results in arrest of progression of atherosclerosis. And if you reduce it to less than 50, it results in regression of atherosclerosis. LDL levels of 30 or even 10 in the 4-year subgroup analysis have produced incremental benefit without any side effects. The side effects which are encountered due to LDL lowering are not related to LDL lowering, but to the drug use. For example, if you have diabetic, it is related to statins and not the LDL lowering. And of late, wonderful technique has emerged for lowering of LDL, that is the CRISPR technology. With this technology, during a single sitting, you can deactivate the PCSK9 gene and slash down your cholesterol to 30 or 40 for the rest of the life. I'll be talking about this in a couple of minutes. So let's see why we are concerned about lipid management. The first reason is cholesterol never sleeps. It works 24/7 and executes its ravages on the cardiovascular system in terms of plaque formation in the arteries. Plaques are the major culprit for cardiovascular disease. They put us at risk of heart attack and stroke, and heart attack is the number one cause of death, and stroke is the number one cause of disability. But more important reason is why we are so much concerned about lipid management is that lipid management has reached great strides, as I'll show you in the next slide. So when we look at the issue, can we stabilize the plaque? The answer is a big yes. A lot of data is available from statin trial. You can stabilize the plaque and decrease the incidence of coronary events. Can we reduce the buildup of plaque? Did it arrest the progression of atherosclerosis? The answer again, yes. Data from the reversal trial, as you can see, and this occurs when LDL is lowered to less than 65. Can we shrink the plaque by lowering LDL, which achieve regression of atherosclerosis? Again, very excellent data from the Glagov trial. And this occurs when LDL is slashed to less than 50. And can we make the plaque disappear by lowering LDL? This is still an unachieved goal. Maybe in times to come, this may become a reality. So at the present state of time, we are running the race virtually to the bottom of LDL. As you can see, ACC 2018, the target for the high-risk patient LDL was 70. 2023, they slashed down to 55. LAI, lipid-associated India, way back in 2016, before the ACC recommended target of 50. ESC 55 in 2019. For a special subgroup of recurrent atherosclerotic cardiovascular event despite statin 40, and the LAI lipid associated India, which I'm also a part. For the extreme risk group, they created LDL target of 30. So the big message for LDL is lower is better and lowest is the best. Why? Because when we look at hypertension and glucose, there's a J curve, but no J curve exists for LDL. So when we look at the evolution of lipid guidelines for the last 35 years, ever since ATP1 came into existence in 1988, what do we find? LDL is the primary target. Non-HDL is the co-primary target. HDL is a fallen angel because all trials of HDL elevation on top of statin has been flop trials, as you can see on the screen. Triglycerides is still under evaluation. All trials of triglycerides lowering like Accord, LLA, Prominent, Strength are negative. The subgroup analysis of Accord LA did show benefit, as you can see, but subgroup analysis only hypothesis generating and there's no large randomized trial at the present state of time. The meta-analysis which the diabetologists often show in favor of fibrates, not all trials were on statins. The reduces trial did show benefit on lowering triglyceride, but when the data was analyzed, the benefit was same whether your triglyceride is more than 150, less than 150, clearly indicating the benefit in reduced trial not related to triglyceride, the other mechanism. LPA at the moment, no evidence-based target, but the pelacarsen phase 3 trial is ongoing. In if this comes out to be positive, we'll have a target for LPA. This shows the curves of the various lipid parameters. You can see the curve of LDL is rising, HDL is fallen, LPA is rising because of pelacarsen, and triglycerides again, some research is coming up. Statin is the drug of choice. The king statin cannot be replaced because statins produces panoply of benefits. It delipidates the plaque, endothelial function improves. You can see the lipid is decreased. The data from the yellow trial, it makes the plaque less hot, promotes calcification, a lot of pleiotropic effects, and also decreases thrombogenicity of the blood so that the probability of a plaque rupture terminating into acute coronary event is minimized, and also has a legacy effect. So statin is the foundational therapy for lipid management, but if the LDL goals are not achieved in 50% of patients, and therefore, as you can see this slide, 50% don't achieve goals. Those who achieve goals, the outcome is improved. So when statins fail to achieve, we have ezetimibe, and if the goals are still not achieved, we now have bempedoic acid. In past we used to shift to PCSK9 monoclonal antibody. All of us are aware of the improved trial. It showed decrease in the LDL from 69 to 53, and this was translated into reduction in the primary endpoint, which was statistically significant. So you can see non-fatal MI decreased significant, non-fatal stroke decreased significant, revascularization was also decreased, unstable angina, CV death, not much effect. And this is the new kid of the block, bempedoic acid, already approved in 2020 for additional lowering of LDL cholesterol in patients with ASCVD or with HeFH, and you can combine it with ezetimibe. The mechanisms all of us are familiar with is a prodrug, is activated by ACVL1 into an active drug, and this enzyme is not present in the skeletal muscle, and therefore skeletal muscle side effects are not seen. And it inhibits the enzyme ACL, inhibits synthesis of cholesterol ahead of statins. The side effects are minor only. You can see hyperuricemia, which is significant, and gout in small number of patients. Other side effects are not significant. Tendon rupture is a very rare complication and is usually seen if you are elderly, taking steroid, chloroquines, or renal failure, history of tendon rupture. But the statin intolerant trials did not report any case of statin tendon rupture. And tendon rupture, as you can see, also seen with statin with ezetimibe. So it's not peculiar to this group. These are the 4 trials: the Clear Harmony and the Clear Wisdom, which is in statin tolerant patient, the Clear Serenity and Clear Tranquility in statin intolerant. And there was sufficient number of diabetics, say from 20 to 30%. If you look at the LDL reduction with bempedoic acid is about 15% when they are on top of statins, because statin also acts on the pathway. But if they are in statin intolerant, it becomes around about 25 plus minus 2. And if you combine both agents, 35 plus minus 2. HRC, high sensitivity CRP, is also decreased substantially in all the 4 trials. Now, in statin intolerance, we can use this combination, ezetimibe plus bempedoic acid, and you can see the LDL can be slashed down to 36. And one of the important combination for statin intolerant is a pitavastatin, ezetimibe, and bempedoic acid. And this is a game changer with the availability of bempedoic acid in the positive clear outcome trial. And this triple combination was tested in an Australian trial, and you can see a 63% reduction in LDL. 90% achieved the goal of less than 70, 58% achieved the goal of 55. Other lipids were also favorably altered, and the clear outcome trial is positive, all of us are aware of. PCSK9 monoclonal antibodies, they slash down LDL by 40 to 60% on all top of all lipid lowering therapy, which translates into additional reduction in the cardiovascular event. LPA is also decreased, and favorable changes in other lipoproteins and good safety, no diabetogenicity. All of us are aware of 4-year trial in stable coronary artery disease, significant reduction of 15% in the ischemic endpoint, and the ODC post-ACS patient, again, 15% reduction in the primary ischemic endpoint. The evopex taught us that they can be used right at the onset of acute coronary event with substantial reduction in LDL cholesterol. And several trials of PCSK9 monoclonal antibodies are now available in ACS, and they improve the outcome. The evopex, the EVAX, the evopex, action, OCT, Huygens, and this I was. For those who are homozygous FH, vacuum has emerged as a boon because its action does not depend on the density of LDL receptors, because statins may not act because LDL receptors are not available, and PCSK9 monoclonal, but this is a boon to patients. Inclisiran, again, slash down LDL by 50%, a single injection, and this remains there for the next 6 months. So adherence is good with inclisiran, but again, is a costly agent, not available in India, but available in UK and other countries. Reduced trial with icosapent was positive. You can see reduction in the primary ischemic endpoint, but when the data was analyzed in less than 150, more than 150 triglycerides, there was no significant benefit, clearly indicating benefit is not related to triglyceride lowering. The trial showed excellent reduction in most of the endpoint. You can see LPA hazard ratio is to the left. PCSK9 vaccine is a new innovation. A single vaccine lowers LDL by 50%. This remains there for the next 1 year. And if the human trial comes out to be positive, they're undergoing, a vaccine every year will be the new way to target atherosclerosis. Seroglitazar is only available in India, not in the other countries, approved by DCGI for type 2 diabetes and for NASH for lowering triglycerides. It substantially reduces triglyceride by 45 to 60%. LPA-driven disease previously was considered a slow death sentence, but pelacarsen is likely to emerge as a transformational therapy for LPA-driven disease, and is likely to become a salvage disease in the future. And we are on the verge of a new dawn in LPA therapeutics. And this is the antisense to ApoA, inhibits the synthesis of ApoA, and therefore synthesis of LPA is decreased. The phase 2 trial was positive and showed excellent result. 97% patients' LPA was slashed down to less than 50, and the Horizon trial is undergoing, and we are likely, we're very hopeful that it's likely to come out to be positive. Gene editing, as we said, has emerged as unbelievable but true technology to slash down your LDL. And the first patient in New Zealand already undergone a successful gene editing with PCSK9 gene editing. Hard-won trial is already ongoing. And the credit for this technology goes to these two ladies who were awarded the Nobel Prize in Chemistry 2020. And this is the video. It has two components, guide RNA and Cas9. The guide RNA locates, you can see this, locates a specific genome, and the Cas9 nuclease gives a double-stranded cut. And when this heals up, you can see the PCSK9 loses its property, and therefore PCSK9 gene is inactivated, and the LDL slash downs to very low level. So when we look at the evolution of lipid therapy, statins are the first oral therapy. We have oral combination with ezetimibe, icosapent, bempedoic acid, and fibrate. Monthly or bi-monthly therapy is PCSK9 monoclonal antibody. We have antisense therapy. Pelacarsen is the one which is going a lot of excitement. Small interfering RNA, we have inclisiran. Olpasiran is still under evaluation. We have PCSK9 vaccine, and gene editing is going to be the future of cardiology. So in summary, LDL is the primary target and has causal relation with HCD. Non-HDL is a co-primoter. Lowering of LDL to very low levels like 30 or even 10 is safe and provides incremental benefit. If you slash down LDL to less than 65, it results in arrest of progression of atherosclerosis. If you decrease it below 50, for the regression of atherosclerosis. LDL can be cut to any size by the current pharmacotherapy. Statin, ezetimibe, bempedoic acid, PCSK9 monoclonal antibody, inclisiran, and now gene editing. Icosapentaethyl is available in India, and pelacarsen is likely to emerge as a transformational therapy for raised LPA. And CRISPR-Cas9 technology emerges a very exciting modality and is going to be the future of cardiology. Thank you very much.